Today's topic is enteric fever, a very important topic of theory and practicals both. The enteric fever is potentially a fatal multisystemic illness caused by Salmonella typhi that causes typhoid fever, and Salmonella paratyphi A, B and C causes paratyphoid fever. First bench Salmonella belong to the family GNB family. They were discovered by Salmon and Smith in 1885. This was first observed by Ebert in 1880 and Gaffke in 1884. So, Salmonella was also called the Ebert-Gaffke bacillus or Eberthella typhi. The oldest classification was typhoidal and non-typhoidal Salmonella, includes the serotypes Salmonella typhi and paratyphi. These are restricted only to the human hosts, enteric fever, typhoid and paratyphoid fever, and non-typhoidal Salmonella mostly colonize the intestine of animals, and when they affect the humans, they cause gastroenteritis and septicemia. According to the antigenic classification Kauffman-White scheme, the serogroups and serotypes were divided into the O, VI and H antigen. Genus Salmonella consists of two species, Salmonella enteritica and bongori. Within the species Enteritica, there are 6 subspecies: Enteritica, Salami, Arizona, Darizona, Houghtonii and Indica. Each subspecies is further differentiated into serotypes based on O and H antigens as described in the Kauffman-White scheme. Taxonomically, the correct nomenclature of the members will be Salmonella species Enterica, subspecies Enterica, serotype typhi. Antigenic structure. There are 3 important antigens on the cell wall: somatic O antigen, flagellar H antigen and the surface envelope VI antigen, which is found in some species. Now, the difference between somatic O antigen and flagellar H antigen, this is very important, and this comes in both the theory and the practicals. Last bench shunchish? Tora. The somatic O antigen, it is a part of the cell wall lipopolysaccharide, and this flagellar H antigen is made up of protein flagellin and is the flagella, so it confers motility to the bacteria. In Widal test, this is the most important test to diagnose Salmonella typhi. O antigen is used, and Widal test H antigens of Salmonella typhi, paratyphi A and B are used. The somatic O antigen is less immunogenic, the flagellar H antigen is more immunogenic. The O antibody appears early, disappears early and indicates recent infection. H antibody appears late, disappears late, indicates convalescent stage. And when the O antigen reacts with the O antibody, they form compact granular chalky clumps. Agglutination takes place slowly, and optimum temperature for agglutination is 55 degrees Celsius. When the H antigen reacts with the H antibody, they form large, loose, fluffy clumps. Agglutination takes place rapidly, and optimum temperature for agglutination is 37 degrees Celsius. Serogrouping is based on the O antigen and serotyping is based on the H antigen. Now, coming on to the VI antigen, this is the surface polysaccharide envelope or capsular antigen covering the O antigen. This was named with the belief that VI is related to virulence. This is expressed only of very few serotypes like Salmonella typhi, paratyphi C, Salmonella dublin and some strains of Citrobacter freundii. The VI antigen is purely immunogenic and the antibody titers are low, not helpful in diagnosis. The complete absence of VI antibody leads to poor prognosis, disappears early in convalescence. If this persists, it goes on to the carrier state. The phage typing of Salmonella typhi using VI specific bacteremia, VI antigens are used for vaccination. Now, coming on to typhoidal Salmonella. Salmonella typhi, Salmonella paratyphi A, B and C cause enteric fever. Transmission, this happens through contaminated food and water by oral route. So, we have to be very careful while taking food and water. The infective dose is minimum 10 to the power 3 to 10 to the power 6 bacilli. The risk factors, what are the risk factors that promote transmission? The conditions that decrease stomach acidity, less than 1 year of age, antacid ingestion or achlorhydria or prior Helicobacter pylori infection. Intestinal integrity, inflammatory bowel disease, prior GIT surgery or suppression of the intestinal flora by antibiotics. Pathogenesis. The pathogenesis is very important. This comes in the exams. The bacteria takes entry through the epithelial cells, M cells lining the intestine. Then there is bacteria mediated endocytosis mediated by the type 3 secretion system. Then they enter into the macrophages. Salmonella containing the vacuoles cross the epithelial layer to reach the submucosa, and then they are phagocytosed by the macrophages. The survival inside the macrophages induces certain alterations on its surface. They are insusceptible to the lysosomal enzymes. Primary bacteremia from inside the macrophages spread via the lymphatics to enter the bloodstream, causing transient primary bacteremia. Then they disseminate through the reticuloendothelial tissues like liver, spleen, lymph nodes and bone marrow, causing further multiplication. Secondary bacteremia occurs from the seeded organs, leading to clinical disease. The clinical manifestations are incubation period is about 10 to 14 days. Step ladder pattern of remittent fever. কিছু কিছু পরীক্ষাতে যখন একটা জিনিসের ডায়াগনোসিস দেবে কয়েকটা কিওয়ার্ডস হচ্ছে ভেরি ইম্পর্টেন্ট। এখানে কিওয়ার্ডটা হচ্ছে স্টেপ ল্যাডার প্যাটার্ন, আদার সিমটমস আর remittent fever. Other symptoms are headache, chills, cough, sweating, myalgia and arthralgia. Rashes called the rose spots. What are the early intestinal manifestations? Abdominal pain, nausea, vomiting and anorexia. Fever will be step ladder pattern, decreasing and then remaining stable and then again rising, step ladder pattern of remittent fever. Important signs are hepatosplenomegaly, epistaxis and relative bradycardia. Another important word is relative bradycardia. The complications are gastrointestinal bleeding and intestinal perforation, which occurs mostly in the 3rd and 4th weeks of illness. The neurological manifestations occur rarely. Hosts. Humans are the only natural host. Transmission, how does it occur? Ingestion of contaminated food and water. So we have to be very careful when taking food and water from outside. It is worldwide prevalent. Incidence is highest in South Central and Southeast Asia. More common in urban than rural areas, more common among young children and adolescents than in adults. What are the factors that favor transmission? Poor sanitation, contaminated water, food and drinks, lack of hand washing and toilet access, and evidence of Helicobacter pylori infection. Typhi versus paratyphi. The typhi infection is more common than Salmonella paratyphi A. The ratio is 4:1. Carriage. Untreated patients become carriers and excrete Salmonella typhi in the feces and urine. So, the carriers are mainly of two types, fecal and urinary carriers. Duration of shedding, temporary carriers for 3 months and chronic carriers for more than 1 year. The chronic carriers, 1 to 4% of the infected people, they are more common in women, infants and old age. The biliary tract abnormalities which lead to increased fecal excretion and abnormalities of the urinary tract and associated schistosoma hematobium infection of the bladder can also lead to increased urinary excretion. They are the food handlers or cooks who become chronic carriers. They become very dangerous, like example is the typhoid Mary who caused more than 1300 cases. Whenever you are eating street food or local food from any street vendor like fuchka and always be very careful and ask him to wash their hands properly. He or she may be a chronic carrier, then you might also get affected. Now coming on to the laboratory diagnosis. The type of the specimen to be collected depends on the duration of illness. There is also a mnemonic regarding this. In the first week of illness, we collect blood, bone marrow and duodenal aspirate. So, B for blood culture and bone marrow in first week, B. Second week, third week of illness, which antigen, serum specimen, Widal, we conduct the Widal test, B, A. Third and fourth week of illness, stool culture and urine culture, SU. So, the mnemonic will be BASU, BASU. So, first week of illness, blood culture, bone marrow or the duodenal aspirate. Mainly blood culture is done because in very few centers we will have bone marrow or duodenal aspirate culture facilities. And in the second week, serum specimen for serology like the Widal test, and third and fourth week a stool and urine culture. The blood culture is positive in 90% of the cases in first week of fever. In where it is done in conventional brain heart infusion broth or agar. Automated blood cultures like Bactec or bacterellar is also used. Stool culture, this is done in third to fourth weeks of illness. Enrichment broth such as selenite F broth, tetrathione broth and gram negative broth are used. What are the mediums? The low selective medium is McConkey agar, where they cause translucent non-lactose fermenting colonies. Bacteriology baki bacteria gulo hoye geche. What are the lactose fermenting bacteria? E. coli and Klebsiella. And non-lactose fermenting? Pseudomonas and Proteus. So, they will Salmonella typhi will also produce translucent non-lactose fermenting colonies. Non-lactose fermenting colonies will produce translucent pale colored colonies, and lactose fermenting colonies like E. coli and Klebsiella will produce pink colored colonies due to fermentation of the sugar lactose. And what are the highly selective media for these Salmonella typhi? Deoxycholate citrate agar or the DC agar, xylose lysine dextrose agar, XLD agar, and the Wilson and Blair's bismuth sulfite medium. Urine culture is done also on McConkey agar in third to fourth weeks of illness. Deoxycholate citrate agar eta, pale colonies with black center, this is the deoxycholate citrate agar, and this is the XLD agar, xylose lysine deoxycholate agar, showing the red colonies with black center. Other specimens are bone marrow culture. This is done in the first week of illness when the blood culture is negative, especially when the patient is on antibiotics. Duodenal aspirate culture is recommended during the first week of illness if both blood and bone marrow cultures are negative and we have a strong clinical suspicion of Salmonella typhi enteric fever. Other specimens, they are a combination of blood, bone marrow and intestinal secretions. This is best method in the first week. Sensitivity is more than 90%. Rose spots passed from the suppurative lesions, CSF, sputum and autopsy specimens such as gallbladder, liver and spleen. If we do a culture test and motility test, they will be motile organisms, gram negative bacilli, and biochemically they are catalase positive and oxidase negative. Give me a name of an oxidase positive organism. Pseudomonas. Indole citrate test, indole will be negative, citrate positive or negative, urease negative. In TSI they will be alkali by acid, gas positive except in Salmonella typhi which produces hydrogen sulfide, tiny small specks. In Paratyphi A, this is hydrogen sulfide is absent, Paratyphi B, hydrogen sulfide is abundant. So, hydrogen sulfide will cause the TSI agar to turn into black. In Typhi, there will be small specks of H2S. Typhi A, Paratyphi A, this will be absent, and Paratyphi B, this will be abundant hydrogen sulfide. Slight agglutination test is done to confirm the serotype, and then antibiotic sensitivity test is done. Now coming on to the most important is Widal test. This is important for both theory and practical. We have to write interpretation also. This is Widal test is done in 2 to 3 weeks of illness. Widal test short note to খুব important, ঠিক আছে? তো কি দেখি আমরা? Antibodies are detected. Widal test very important for both theory and practical. This is done in 2 to 3 weeks of illness. Antibodies are detected against the TO, TH, AH and BH antigens. Salmonella typhi infection, there will be rise of TO and TH antibodies. In Paratyphi A infection, there will be rise of TO and AH antibodies. In Paratyphi B infection, there will be rise of TO and BH antibodies. Okay? In O antibodies will produce granular chalky clumps when react with O antigen, and the H antibodies will produce cotton woolly clumps when reacting with H antigen. These readings are taken in a concave mirror. When will be the group C will be coming for the practical classes tomorrow, I will show them the Widal test interpretation. Okay. The serial dilution is done. This is showing a titer of TO 1:160 and TH 1:320. Now this is very important, interpretation of the Widal test. Rise of TO and TH antibody is suggestive of fever due to Salmonella typhi. এটা আসবে বাবা, থিওরিতেও আসবে, ভাইভাতেও জিজ্ঞেস করবে. So the interpretation of Widal test, this is one of the most important tests in our practical also. This will be asked in your examinations by external, পরীক্ষায় পারফর্ম করতে হবে, ঠিক আছে, আর এতেও থাকবে. প্লিজ একটু মন দিয়ে দেখে নাও 2 মিনিট. Rise of TO and TH antibody is suggestive of enteric fever due to Salmonella typhi. Rise of TO and AH antibody means enteric fever due to Salmonella paratyphi A. TO and BH antibody is due to paratyphi B. Only TO antibody rise signifies recent infection due to any serotype, and rise of TH antibody will suggest convalescent stage or anamnestic response, and rise of all the 3 antibodies will signify post TB vaccination. There all the antibodies will rise, TH, AH, BH antibodies. Okay. While this false positive kishe kishe ashbe, Widal test may occur, false positive reaction may occur due to anamnestic response. It refers to transient rise of titer due to an unrelated infection like malaria or dengue in persons who have had prior enteric fever. If the bacterial antigen suspensions are not free from fimbriae, persons with inapparent infection, or persons with prior immunization with TB vaccine. The false negative Widal test may occur in early stage, the first week of illness, late stage after 4th week, carriers or patients on antibiotics. Due to the prozone phenomena, antibody excess, this can be obviated by the serial dilution of the sera. The O agglutinins appear early and disappear early, so this signifies recent infection. H agglutinins appear late and disappear late. তাহলে ওটা সবার আগে আসছে, তার ওটা রাইজ মানে হচ্ছে recent infection. O antibody appears early and disappears early, recent infection. H agglutinins appear late and disappear late. The O antibodies are serotype non-specific. They are raised in all infections like typhi, paratyphi A and B. H antibodies are specific. TH, AH and BH antibodies are raised in typhi, paratyphi A and B infections respectively. What are the other antibody detection tests? Typhi dot test. Here a 50 kilodalton outer membrane protein OMP antigen is used. It uses a dot ELISA format to detect the both IgM and IgG separately after 2 to 3 days of infection. Ideal Tubex test, O9 antigen is used, detects only the IgM antibodies against typhi by a semi-quantitative colorimetric method. IgM dipstick test and ELISA, this detects the anti-LPS IgM antibodies. Dot blot assay, the flagellar antigen is used, detects only the IgG antibodies. Other serum antigens, ELISA, molecular methods hoche PCR, flagellin gene and D gene. Other non-specific tests are neutropenia. LFT is moderately deranged, muscle enzymes are moderately elevated. Whenever you are writing any laboratory diagnosis and you cannot remember anything, last একটা line রেখে দিবি, molecular test PCR. And how the detection of carriers is done? By culture, because they are shedding the bacteria in stool and urine. By stool and bile culture for fecal carriers and urinary carriers, urine culture. Detection of VI antibodies is done by tube agglutination test carrying the VI antigen like Bhartnagar strains. A titer of more than 1:10 is considered as significant. Detection of carriers, isolation of Salmonella from the sewage, sewer swab technique. Gauge pads are left in the sewers and cultured on highly selective media like Wilson and Blair media, and the sewage can also be filtered through millipore membranes. That membranes are cultured on highly selective media. Now coming on to treatment, prompt administration of appropriate antibiotics prevents severe complications and reduces the mortality to less than 1%. Treatment of the cases depends on the susceptibility of the strains. The currently recommended drugs are as follows. Third generation cephalosporins are used. Ceftriaxone is the drug of choice, 1 to 2 gram per day. This is given as IV for 10 to 14 days. Azithromycin is the alternative drug for empirical therapy. Fluoroquinolones because of the increased drug resistance, but this should not be given empirically because of drug resistance. In past chloramphenicol cotrimoxazole was used. Treatment of carriers include ampicillin or amoxicillin plus probenecid given for 6 weeks. In multi-drug resistant Salmonella typhi, these are resistant to chloramphenicol, ampicillin and cotrimoxazole. The fluoroquinolone resistance, the key mechanisms responsible are mutations in the gyrase A and PARC genes. Resistance to ceftriaxone is very rare, but both ESBL and ampicillin beta-lactamase producing Salmonella typhi has been detected. Now, prophylaxis, we have to control the reservoir, proper sanitation and vaccine. Control of carriers is done by early diagnosis and proper prompt effective treatment. Disinfection of the stool or urine soil clothes with 5% cresol, 2% chlorine or by steam sterilizer. Follow-up examination of the stool and urine culture to detect the carriers twice at 3 to 4 months and at 12 months. Control of the carriers, early detection of the carriers by stool or urine culture or by detection of the VI antibodies. Effective treatment of the carriers is done by ampicillin or amoxicillin 4 to 6 gram per day plus probenecid 2 gram per day for 6 weeks. In surgery for cholecystectomy plus ampicillin is given. Sanitation, protection and purification of the drinking water supplies. Wherever you are going, I will suggest all of you to use at least mineral water. যেখানে ভালো জল পাচ্ছিস না, mineral water কিনে খাবি. Hand washing and improvement of basic sanitation. Proper hand washing is necessary. Varsha, whenever you are eating fuchka, you will ask the food handler to wash his hands. Promotion of food hygiene and health education. Vaccine. Vaccine is also another important short note topic. Immunization provides short-term protection as indicated in the following situations like travelers going to endemic areas, people attending melas like Ganga Sagar Mela, household contacts, people at increased risk, school children, people living in endemic area. What are the vaccines for typhoid fever? This is also another important topic for short note. Parenteral VI polysaccharide vaccine. Purified VI capsular polysaccharide antigen is derived from the Salmonella typhi strain type 2. Dosage, single dose intramuscular or subcutaneously. This gives a protection for 2 years. Booster is required for every 2 years. Age at least more than 2 years of age. Or the VI-REP antigen, where the VI antigen is conjugated with the recombinant Pseudomonas aeruginosa exotoxin A. This can be given to children less than 2 years. Typhoral or the oral live attenuated Salmonella typhi type 2 1A vaccine. Here stable live attenuated mutant strains of Salmonella typhi strains 2 1A is used. This is a GAL-E mutant. This lacks the enzyme UDP galactose 4 epimerase. This multiplies for some times, initiates the immune response but self-destructs after 4 to 5 divisions. This is indicated only after 6 years of age. So, age wise আমরা একবার দেখে নিই parenteral vaccine যেটা VI polysaccharide vaccine সেইটা দেওয়া হয় more than 2 years of age এ 2 বছরের পরে দেওয়া হয় parenteral VI vaccine টা. Typhoral vaccine 6 years of age এর পরে দেওয়া হয় oral vaccine live attenuated vaccine আর parenteral VI polysaccharide vaccine টা দেওয়া হয় children less than 2 years আর oral টা after 6 years. The typhoral vaccines, the oral live attenuated vaccines, these are enteric coated capsules. This is given before food on alternative days 1, 3, 5, 7 with booster every 5 years. This protective immunity starts after 7 days of the last dose and lasts for 4 years. Parenteral TAB vaccine, this was a heat kill vaccine, but this is not used now because of side effects. Now just a non-typhoidal salmonella, overall this comes for just a short note. This has mainly causes the gastrointestinal manifestations, However, 8% of the patients of the gastroenteritis develop into bacteremia, lead to either endovascular infection or seeding to various organs, leading to metastatic infections. Risk factors are most common being Salmonella choleraesis and Dublin. Infants and elderly people at risk, and patients with HIV and other conditions with low immunity, or patients with pre-existing valvular heart disease. So, what are the infective doses of Salmonella typhi? 10 to the power 3 to 10 to the power 6 bacilli. In a patient with typhoid, diagnosis after 15 days কিভাবে করব? Widal test. Antibodies against which of the following antigen appear in a carrier? VI antigen. Okay. So, we are coming on to the end of enteric fever.